So I want to welcome everyone to the latest Scale Leadership Series. I'm joined by Victor Schmerbeck. Victor has been the CEO of Emerus for quite a while now, over 10 years. Is that fair to say?
No, since 2019, I've been with the company. I ran our development group for a period of time, but since summer of 19, I've been.
So 6 years.
Yep. Doesn't feel that long.
Yeah, it goes by quickly. It really does. So excited to speak to you about Emerus. But before we get into Emerus, why don't we start as we always do with our CEOs, which is how did you end up being the CEO of Emerus? What was the journey like?
It's a great question. So the predominance of my first probably two decades was on the investment banking and investing side, and for the latter part of that, all healthcare services focused. Emerus had actually been a client when they did their first transaction with a growth equity firm, and then when we did a transaction with our current sponsor, Welsh Carson. I had come in to lead development and help grow the business, and then ultimately stepped in, as we discussed, into the president and CEO role. I love what we do as a business. I actually love the notion of kind of leading people and strategy. So in many ways, I wish I had gotten there earlier in my career. It's been a fun journey.
So you joined Emerus. Why Emerus? What motivated you? What attracted you to that asset? And maybe just describe it. What does it do today? What was it doing at the time? Yeah, a little bit of background on the company.
Yeah, of course. I half jokingly say I think Emerus has lived kind of 5 to 6 year lives. Business was founded in 2006 by a handful of physicians, really just looking for a better care delivery setting for both patients and themselves and staff, right? And so it was a relatively small company at the time. They were focused on emergency services solely, but really developed a workflow methodology and care delivery model that resonated with patients and families. It also resonated for employees and physicians. And that was the pretty simple goal in the beginning. The early 2012, they made a pretty significant strategic shift, which was partnering with leading incumbent health systems and focused on doing more from a care delivery standpoint to enable patients to stay in their community when they needed levels of care that were higher than just emergency services. And integrating and aligning with large health systems. So, the first partners were Baptist Health System in Texas-based company, Baptist Health System in San Antonio, Baylor Scott & White in Dallas, Fort Worth. And then we went through, candidly, a period of a handful of years as a company, and this predates me, to a degree of what does it really mean to be a partner with a big health system, right? You kind of went from we own and control everything to where you're aligning strategically with a big health system, and how do you really get into that culture of network management, capacity management, and being a partner aligned with an incumbent health system. And then the last period of time, which is more my tenure, certainly a part of the middle tenure too, was really getting us prioritized into what are we really good at? What are our core competencies? And nothing against many entrepreneurs, physician or otherwise. Oftentimes there's a lot of squirrels running around the table, and getting focused on what we really think where we can add value to payers, we can add value to patients, we can add value to families, and add value to our employees and our health system partners. And so we narrowed our list of things that we really focused on. And then have accelerated our growth in our health system partners. We have 12 health system partners today. You asked about basis of Emerus, but we co-own, manage, and operate small format hospitals really across the country, from Washington State to Pennsylvania and in between.
I counted over 40. Do we still call them micro hospitals?
The market for some reason developed a nomenclature of micro hospitals. We don't call any of our facilities micro hospitals. They're typically referenced as neighborhood hospitals. And I think uniquely what we've done is
That is a more pleasant term, isn't it?
but one of the
When I
things
think
that
micro hospital, I think almost like a toy hospital.
right. Yeah, exactly. So, and I think it's important to note too that in virtually all of our facilities, there's co-located ambulatory and outpatient care settings. So our neighborhood hospital would be on the first floor, and happy to get into kind of the construct of that. But the first floor, the second, and sometimes even third floor are primary care, pediatrics, women's services, outpatient rehab, PTOT clinics, IDTF outpatient imaging, and then more recently, even where our partners are co-locating ambulatory surgery centers as well.
So you're really creating hubs.
Correct. We call them kind of community care centers or health plexes, but when I think about our strategic goal, when we go into access points that support our health system partner strategy, is we want to be able to care for 90+% of that community's needs, right? If they need a high-end oncological, neurological, some other cardiac, intensity, we're unified on EMR, be it Epic or Cerner. It's a direct admission. That patient knows they're going to see Dr. Jones in room 806, and all the care records are there for that patient. But the proximate, and this is a national average, on average nationally, patients drive 34 minutes to get to healthcare. In our setting, it's less than 10 in every market. And in most cases, it's 6 or 7 or 8 minutes.
So you're bringing healthcare to where the patient lives.
Correct.
Easing access, probably resulting in more care, better outcomes, better health, making communities happy. The 40+ neighborhood hospitals that you have, are they all hubs the way that you're describing for the majority?
There's a few that are not, but the vast majority.
Vast majority. And are they all, so the anchor is predominantly Emerus, starting with the first floor, this is what we're doing, and then the word gets out to other provider groups, why don't you join us in this construct? We're going to need an orthopedic group, we're going to need a primary care group. And by the way, we've partnered with Baptist or Baylor, and we anticipate the health system is going to be an eager partner to you, Mr. and Mrs. Orthopedic Group on the 4th floor, as long as you recognize the need to coalesce around a single EMR and share data.
So the only thing we pre-program the building in advance, right? So, and you said Emerus is on the first floor. You're never going to see Emerus on any of our buildings, right? In Dallas-Fort Worth, every facility is Baylor Scott & White. In Las Vegas, every building is Dignity Health, right? In Pittsburgh, every building is Allegheny Health Network, WellSpan, Christiana Care, Ascension.
So it's strictly a white label service.
Correct. And we pre-program with our health system partner the 2nd and or 3rd floor in advance. So when we open the hospital, the 2nd floor, the 3rd floor is opening maybe not exactly the same time, but within a matter of a few months.
Are these employed groups from the system, or are these affiliates in the system?
Either employed or strongly affiliated.
Strongly affiliated. So it feels like a Baylor building.
It's completely a Baylor Scott & White building.
Got it. Okay. And so from the health system's perspective, how much capital are they being asked for to fund and maintain that building? Are they on the lease? Are they in the CapEx, the build out?
So we
staffing the first floor with their registration. How are they looking at it in terms of spend?
Yeah, so we create a separate business entity that we co-own together. It's typically owned 51% by the health system partner, 49% by Emerus, and we deploy capital on a pro rata basis to that ownership structure.
So they've at least got a half partner in you.
Correct. And so, if you think about why does a health system partner with someone like us, I would start with speed to market, execution, in terms of I'm biased, but I believe we're very good at operating small format facilities.
At a minimum, you're focused.
We're very focused.
You're not doing that within the system plus 10 other projects.
Correct. And so we have a very focused, dedicated kind of soup to nuts team from site selection, development, programming of second and third floor, who we need to hire and why, how we cross-train people inside the buildings, the type of physicians, the workflow elements inside the building. And we're very focused on driving efficiency for both patients and families, as well as a great work environment for our employees and physicians.
So is your partnership, the 5149, extends all the way through the entire building? And so
no, it does not. It does not. So to be clear, it only extends to the neighborhood hospital. And then on the primary care, you know, be it rehab clinics, women's services, pediatrics, what have you. And I think it's important to note too, that when you're looking at the submarkets, I don't know how well you know, I'm in Dallas today, but you know, Dallas, Fort Worth, most people listening to this probably never heard of the communities we're in. We're in Murphy, Texas, Rockwall, Texas, you know, Grand Prairie, Burleson, Mansfield, Keller, Colleyville. Those are all kind of suburbs, and each one of them uniquely has a different population mix. So if it's an older community where it's more tends to be more either retirement or Medicare, you know, or later stage commercial from an age perspective, you're going to program the second floor differently, right? You're going to have a different suite of specialists. You're typically going to look more at, you know, having rehab and imaging, things that community needs more. If you flip the script and you go to it's a young family suburb, then you're going to typically have OB and pediatrics and women's services. So you're really tailoring the offering to the community, a 15-minute drive time, a 20-minute drive time kind of orientation. But that ultimately is our partner bringing their physicians, their rehab, whatever service it may be.
Victor, are they bringing their patients too, or is that left on your plate?
No. And the beauty of, look, not everybody needs to be in a neighborhood hospital for an acute episodic event or, you know, an observation or inpatient stay. But people go to their primary care, their pediatric, you know, office or for rehab, what have you, all the time. So it creates an opportunity for that hub, as you said, or healthplex, you know, to be active on a daily basis. And they're not having to go downtown and park in a 6-story parking garage. And
is that the main source of patients for the second, third, fourth floor? You're on the first floor, you're retail, you're visible, you're almost like an urgent care center is visible, exactly like an urgent care center, but with more services offered.
with a much higher degree of service.
But they view you really as almost like a retail concept. They view you as the anchor tenant drawing in patients that then flow through into the rest of the building. Yeah.
So if you, to that point, when you think about, if, you know, again, going down the path of Baylor, just because we're on that one, but it agnostic to health system, they can put a primary care group and a suite of specialists that either rotate, that are maybe there, you know, 2 or 3 days a week, or maybe there every day of the week. There are many people that come into our facilities that do not have a medical home, unfortunately, right? So our ability to, at post-discharge, identify that patient to a primary care physician in the same location that they can create a medical home with, or a pediatrician, what have you, allows the health system to get the benefit of growing that panel more quickly than maybe if they just were isolated in an MOB away from, you know, a larger healthcare destination point.
And so are you getting patient referrals from urgent care centers who have tapped out in terms of their abilities? Yeah.
Correct.
So it begs the question, at least from my mind's perspective, as you sit and you look out at the thousands of urgent care locations across the country, I don't know if it's tens of thousands, but I wouldn't be surprised if we're getting there.
A lot.
Yeah. Why aren't there tens of thousands of community hospitals, neighborhood hospitals, the way that you define them, with deeper, really urgent care capabilities, ER capabilities, that are more capable of responding to a broader suite of patient needs, that's highly efficient, that then flows in on behalf of the health system's benefits into these other specialists? You'd think that the model, not just conceptually, but practically at Emerus makes perfect sense. It's almost like I'm listening to a CEO who's running a great orthopedic MSO, and yet where are the other 500 orthopedic MSOs? Why isn't this more established?
I think there's a continuum of care, and we don't have a script here, but if you think of just a triangle from a pyramid standpoint, and I'm going to the acuity of the patient, right? And at the top end of that, the peak of that, we should have the fewest facilities that we have, which those are the tertiary and quaternary facilities. And they should be, in our opinion, a very high center of excellence. And I think what we're seeing with many of our health system partners is they're beginning to rationalize services based on the size and scope of their facilities. So instead of trying to put every service line in 20 hospitals around Dallas-Fort Worth, you're creating hubs of excellence around cardiac, oncological, neurological.
Disintermediating.
So that at the top end, the fewest number of facilities, in my opinion, that we have across the country.
And you're seeing that. You're seeing the number of hospitals that's gone from 8 to 10,000 down to 4 to 5,000 over the last 40 years.
Right. As you slide down the acuity scale, right, and going from top to bottom, the bottom has
to fill out.
The bottom has to fill out, and those tend to be physician clinics, urgent care, things of that nature. I think we fit in the middle of that, right? We're a piece of the puzzle. We're not the sole solution. And there's a ton, as we've seen with, on the surgery side and even on general inpatient care, there's a ton that is going from the top end of that and sliding down because our length of stay, and this is actually payer data that I'm quoting here. We get it from our partners too, but the same risk-adjusted patient has a length of stay in our facility that's almost half of what it would be in a big box hospital.
Is it fair to call what you're doing predominantly outpatient ER?
No, well, we do have observation care, but we take care of people that need to be in the hospital. It's generally non-ICU care, so it'd be step-down unit and med surge, general medical services, somebody that needs to be in the hospital for 2.5, 3 days. There are some longer, stay patients.
Outpatient ER and short-term stay. Fair?
Correct.
So,
and that general patient is spending 4+ days
yeah,
at a big hospital, and the cost. So 3 things I would point out: materially shorter length of stay, 40+%, lower total cost to the payer on the order of 20%, and lower readmission rates. So national average on readmission is 10+%. We sit at 1.2%.
Let me get back to that in a second, because I've no doubt that you offer a lot of efficiency gain based on your focus. But let me just ask at a macro level, how many of these neighborhood, micro, outpatient, ER plus short-term stay, so that's sort of the terminology, the box.
Right.
How many of them are there in total across the country?
It's about 150 today.
How many should there be?
And we're a third of it.
How many should there be? We had limitless.
I could make an argument that
we had perfect information.
Yeah.
And
I could make an argument that you should look at every hospital that's 50 to 150 beds that has historically tried to put everything into a small box, rationalize those campuses, get your high-end tertiary quaternary stuff to a center of excellence, and that 100-bed hospital that's been there for a very long time could be much more efficient with a 20 bed, 25 treatment room.
So we reduce the beds, we reduce the size of that hospital's ER.
I think you'd look at the volume in a given facility. We think about the acute episodic side in kind of pods from an efficiency standpoint. So you kind of look at what's the
look at utilization.
Right. So we often have this discussion. It's interesting, and it's maybe a little cynical in my comment here, but you get an ER staff or you get a team in a 50, 80 bed ER, and they're like, well, it's easier for you because you have less rooms, it's more efficient. But then when you look at it and you say, but you're turning over your room 4 times a day, we're turning over our room 8 to 10 times a day, right? Just due to the efficiency.
Yeah.
And some of it's not rocket science, right? If you're in a big health system campus, big medical center.
Your feedback to Mr. and Mrs. Hospital is predominantly you've overbuilt.
Well, it's not just that, but and it makes sense why they do it, right? You share lab, you
They've
share
bundled,
imaging, you
but they've
share all this stuff.
right.
So it just takes longer. We have dedicated CT, we have dedicated lab, we have, um,
The history of all business, as I heard one day in this throwaway quip from, I think it was the founder of Intel, but it's one of those truisms that's been floating around the West Coast forever, is the history of all business is defined by two words: bundle and unbundle. And so the hospitals have been bundling, and you're in the
yeah.
business of helping them with the unbundle, because there is such a thing as bundling too much. So that's interesting. Okay, so back to my question. If there are 150 of these today, 200 of them today, how many should there be?
I've never really sat down and looked at it's a great question for our team, maybe one that I follow up on.
Yeah, look,
I
we
mean,
used to think that, let me give you an example. We used to think that 6,000 ASCs was a good number. And we used to show up at the Becca conference for ASCs 15 years ago and hear that, painfully, we've reached the peak of maturity. And everyone used to look around and frown their heads and go, oh God, no more growth in the ASC space. And I always found that view to be a little bit of crowdthink. It didn't quite resonate with me. I'm always a little bit skeptical of crowdthink, as you know.
yeah,
And lo and behold,
it could be 3 to 5 times it is today.
20 years later, there are 10,000 ASCs in America.
There's no
Crowd was
doubt
not
in
the
my
right number.
mind that, I mean, we're on a path, and Roy, you and I have talked about this to some degree. As we've evolved and we're now have 12 different partnerships, and the evolution of each one of these is typically, you start with 3 or 4 facilities as a first phase, right? We started in San Antonio, our most mature market. We started with 3 facilities. Today we have 9, and we're opening our 10th in 2025. We started with Baylor Scott and White with 5 facilities. We're now at 8. We're adding more, right? So in Las Vegas, we started with 4 just prior to COVID, so it delayed some of the maturation process. But we're opening a 5th this year. We'll open a 6th next year, and we're looking at number 7. So the embedded growth inside of our existing partnerships, which I think also goes to the health system, is seeing value in what this provides to their overall network.
Because some of those patients, not because, but in addition to all of those patients flowing through that building, that location that you've created, whether it's the first floor or the 8th floor, I would imagine a good number of those patients find their way back to the health system as well, where the health system is 100% owner, and happy to receive them. Is that fair?
No, very fair. We opened a partnership with Allegheny Health Network, which is actually owned by Highmark Health, the very large Blue Cross Blue Shield provider in Western Pennsylvania. So it's Pittsburgh and that surrounding MSA. The dominant provider for a very long time in that market's been UPMC, University of Pittsburgh Medical Center. So if you look at the first, call it 18 months of data that we had, and we opened we opened the first one in February of 2020. And then we opened in March, May, and August. So we have 4 facilities there. Interesting time to open. I'm told we were the first virtually accredited facility by Medicare ever. I don't know, never validated. I don't care.
Virtually accredited. That's amazing.
Yeah.
Did they get a tour on camera? That's funny.
Now they came back and obviously did a physical later, but nonetheless, the point I was making is on the order of 25 to 30% of the patients that presented at our neighborhood hospitals over the first year was the first time that patient had ever touched Allegheny Health Network. And then you think about the reattribution rate, to your point, back to either their primary care, a GI specialist, a specialist of sorts, or, if they needed a higher level of care, to the hospital, was a very high percentage. So if you think about network capture for the system, there's a huge benefit of getting into the communities where you can provide services instead of telling patients and families, we're going to plop ourselves in downtown and you come to us.
Yeah, I think we went through a mind shift in healthcare in hospitals. So I want to get closer and closer to it because I actually think these hospitals are coming to my world where I live, where I grew up, and your world where you live, you grew up, which is all performance. And just like I have a nervousness, a sort of an instinctual reaction to crowd think, not that I'm not guilty of it too. I'm guilty of everything that everyone else is guilty of, but at least I have a sense for it that causes a reaction. I also have a sense for bloat and excess investment that causes a reaction. And I think the hospitals went through a paradigm shift where 50 years of incessant spend measured carefully, you can see the inflation rate, you can see the percentage of GDP, results in a heavy focus on assets, big campuses, big brands, big locations, prime locations, downtown, downtown, downtown. And I feel like these hospitals, it's so healthy in partnering with you, are really representing where their mind is at today. And it is a shift far more focused on performance, small, local, easy, patient experience, right? First, second, third floor, speed, right? A word that was never associated with large hospitals, a cost. So I think it's a really interesting time, and I love it. Just like the surgery center space has benefited from the same hospital, not just participation, hospital leadership now. At 6,000 ASCs, it was hospital participation. All of those 6,000 ASCs were really managed by other groups. But at 10,000 ASCs, there's a lot of hospital leadership there as well. And I think your space will probably over time see more hospital leadership just as much as there is hospital partnership. But I want to talk about reimbursements because I'm curious. Hospitals are still being pointed at as an anti-force, a counterforce to value-based care, performance-based reimbursement. How does that reconcile with all this successful inherent coordination that's going on in your locations between the first floor, the 8th floor, and the hospital partner or parent? How does that translate to coordinated care from a reimbursement standpoint?
So I think in our world, and we spend a lot of time with people like Highmark, who's a partner of ours. I think they're the, I don't know, third or fourth largest Blue Cross provider in the country. We spend time with other payers as well.
Have you spent time with Kaiser at all?
We're not in a market where Kaiser really is. And so, I mean, we have dialogue with them, but it's not, we're not embedded in a market. We've been in markets where they've tried to come in and do something, but
yeah, they recently entered Pennsylvania. So it's going to be interesting to see what
and look, we don't need to get off on Kaiser. I mean, they have a very unique model where they dominate and where they own all the, they own the physicians, they own the hard assets, they own the health plan. I think history would tell you they've had a harder time going just with the health plan into a market without being able to bring
very different when you're one of many.
Right. But on the coordination of care, we really think about it from the entire episode of care. So when we sit down with a Highmark, for example, and we look at coordination of care, the neighborhood hospital is typically a piece of the puzzle, right? So the question is that patient being readmitted? Do they go to a higher level of care? Do they need follow-up? And more importantly, are we getting them to the best value and quality from a follow-up standpoint? And so that's where being integrated on the EMR, really being coordinated with your partner and the payer partners on, hey, if I'm in, we're in Westmoreland County, in the Hempfield area, which is kind of south of Pittsburgh. And in that location, we have our neighborhood hospital. AHN has a cancer center. We've got a suite of MOB. We've got 60,000 square feet of healthcare in that facility. But uniquely looking at, okay, if I have a GI issue and someone at discharge needs to follow up, we have a notion in our EMR where it says, and it may be someone that's part of a shared savings program with Highmark, right, on a value basis. But hey, here's the top 3 GI groups as it relates to cost and quality. So let's get that patient, if they don't have an identified GI specialist, physician, how do we get them to that group, one of those groups? And we schedule that appointment at discharge. It's not, hey, you need to follow up with a GI doctor in the next week. It is, we're looking at the schedule of Dr. Jones, and he or she is available on Tuesday at 9.
So it's interesting. You're playing this nexus role where you're at a point of inflection where a procedure leads to a follow-on referral, acute, post-acute, pre-acute. So you are almost like a train station, the way that a primary care group can be a train station, but you're really focused on episodic acute care versus primary care.
Versus primary care, where we're going to see patients that are sicker.
Yeah.
The 90+% of our patients are, in the acute episodic world, the higher the number on a level code, the more acute they are.
So
the vast majority of our patients are level 4 and 5, right? 3, 4, and 5. We don't see low end patients for the most part. And frankly, when we do see them, they tend to be Medicaid because they don't have another option.
Yeah. All right. So that's another challenge. So per member per month is not an option for you. Wellness visits not an option for you. You are squarely focused on the ER plus days. But nevertheless, you are driving performance, generating savings, reducing readmission rates. So all that benefit is flowing to the system. And your point to me is, hey, Roy, for whatever clinicians, specialty groups, primary care groups are enrolled in value-based care programs who are sharing in those savings as a result of my actions, they're getting a bonus payment, a savings payment. They're getting higher star ratings, higher per member per month.
By the way, star ratings is
so the residual flow into value-based care. If the hospital that I'm partnered with or the health system is participating in savings programs, they're benefiting too. Emerus.
So think about that. Think about this.
We're not necessarily focused on contracting directly with that. Is that fair?
It's fair. I would love to find a way to participate, in that. I don't think where we found value in our world, in the sense of, if we can truly, which the data suggests, we can lower the total cost on an episodic basis. We can get that patient to the right place post-discharge from a follow-up standpoint. Where we get the benefit is payers altering member plan design, employer groups really motivating their members to go to our location. So it's not a shared savings model. It's more of, we can be more efficient. You asked earlier about, do we get referrals from urgent care? All day, right? And the proposition we're giving to them is, we can take better care of your patient at a lower cost. Right, when they need a higher level of care. And so that coordination piece, we believe, gives us the opportunity to grow same store volume outsized to the market. And so it's, and we're aligned as it relates to our health system partner in that regard.
You're looking at value-based care programs the way that a successful ASC management company looks at them. I know that I'm part of the solution, but I haven't necessarily been invited to the party yet.
Correct.
So
very good way to say it.
I want to share this podcast with my payer team, and I want to share this podcast with the former president of Sound Physicians, who's a member of Gold as well. So he'll join us shortly when we head out, and hopefully you'll come to that too. Because I think about maybe Sound Physicians as an interesting comparable, in that they were focused, they still are, on ER management within health systems across the country, but also extended their reach into the catchment area, the affiliate groups, in driving coordinated care on behalf of health systems as well. And I think, if I'm not mistaken, I never worked there, but they ended up participating with health system support in a lot of performance-based reimbursement programs. So I think that will be an interesting conversation as well. So
it's certainly an opportunity that we have our eyes on. I don't have the answer today.
Yeah, look, it's all good. It's all good. Obviously, the value that you're creating is recognized and leading to more growth and leading to more savings. So it's not like coordinated care isn't working. And this is a thesis that my partner Jason and I have been driving home across the industry for as long as possible, which is, there's many different ways to coordinate care, and they don't all have to flow through CMMI, right? So that's interesting. So two themes that I really want to dive into before we finish up, that are very near and dear to my heart, that we come back to again and again. And you are squarely in the heart of both of them. One is private equity in healthcare, and the other is MSO hospital health system partnerships. And I actually think the two are very related. The point that I make to the private equity community whenever I can, all of them, is the number one value generator that they have created for healthcare in America is creating MSOs. Because without MSOs, there would be no MSO hospital partnership. It would just be hospital and practice, which is what the world that you and I grew up in healthcare. Hospitals and practices, and no third option. But as soon as private equity helped fund a lot of these MSOs to scale, suddenly hospitals had large, bulky companies, teams, credibility, history, marketing, capital, partners that they could reach out to and say, hey, I've got a challenge here, and I don't have what I need to solve it on my own. Can you help? Fair?
Fair. Very fair.
Right. So let's delve into the second one, hospital partnerships.
And I would say, look, if you go back and you were in San Francisco for the JP Morgan conference, and you can read Becker's or Modern Healthcare, all their recap notes, it doesn't really matter. The three primary themes were, at least from big health systems, right, was move to outpatient. We know we need to partner, and we need to figure out how to capacity manage our facilities.
And they're right on all three.
To get the patient to the right place for the right reason at the right cost. In a lot of cases, that means, and it's hard, but if I go talk to the chief financial officer, CEO of all of our health system partners, they're highly aware that they have 20+% of their patients that are margin dilutive, staying too long in their building, creating backlog of getting patients that really need to be there into a bed, and they're trying to figure out a solution.
Are you okay? I'm going to stay on.
Yeah, go.
I'm going to stay on time because I have so many questions. All right, so back to the hospital partnership question. What are the ingredients that you look for that are musts, and what are the yellow flags that raise suspicion that this might not work? And what are the red flags that you walk away from? What have you learned in all partnerships?
That's actually a really great question. Look, the very first, and I think the foundational, is we have to have strategic alignment, right, with our health system partner. And I think we feel like, we need to be, we're creating a marriage. It's not negotiate a prenup just in case, but it is a marriage, and we're going to be embedded. Every one of our market CEOs sits on, the CEO council, president council of the big health system. We are fully integrated. So that alignment, we're looking for strong brands and strong markets. I think those are probably easy. You can do your calculus with data analytics on markets and who you want to partner with. But the strategic alignment is really the core of it.
I want to go back to that. I just want to unpack what you said. You call them CEOs, are sitting on health system boards?
Not on the board, but take Baylor Scott and White, they have, or Baptist Health System, right? The leader of that market overall for Baptist Health System typically would have like a president's council or CEO council or operations council. And it would be, the hospital president.
His hospital CEOs would join.
Correct.
Every month, every quarter?
Oh, no, these are off. In some cases they're weekly, but certainly monthly.
Your representative for that region, for that location, is joining their hospital CEOs in that CEO council on as much as a weekly basis. Correct. In perpetuity.
In perpetuity.
So it feels like,
and it goes down the list.
So you're deeply embedded.
Yeah. Same with our chief nursing officers as it relates to quality, infection control, environment of care. Same premise.
And they probably have a technology department, and you're probably meeting there as well. And so you sprinkle out your org chart, and there's a counterparty at the health system for every one of those org chart department heads.
And then below that, Roy, when you think about, not every one of our neighborhood hospitals, the submarket community, is going to refer or deal with every hospital of our partner. So they tend to have a sister facility, right, that they're closest to.
Their go-to,
right? And the big health system is actually referring patients to us, and we're referring patients to them. And so below the CEO, CNO level, our hospital administrator and the administrative team at that hospital have their own, kind of cadence of how they work together.
So one of your global master questions, overriding questions is how deep will we be able to integrate with this group? Because Lord, I know a lot of integration is going to be required. And if you're getting pushback along the way, so now we get into the yellow flags and the red flags.
So yellow flags
is not interested in speaking to you. Their nursing team is very difficult to work with. They don't communicate well. So these are the beginnings of yellow flags, red flags. So walk me through. What do you look for?
Yeah, so it's interesting. One of the things that we've done, and I'm going to say this, and I mean it deeply because I really don't mean it to sound like it's arrogant. But when we begin a discussion with the new health system, one of the things that we've put down as a criteria is we want their clinical leadership team to come into one of our markets and see our facilities. And we want them to do that within a defined period of time, right? That's reasonable. And what we found is when we get them into our facility and they get to see, talk to physicians, talk to clinicians, talk to our leadership team, and they see kind of what we do, it accelerates our opportunity. And sometimes it may be a no, right? But it's a quicker no, if that makes sense, if it doesn't make sense to them. But more times than not, it accelerates our discussion and it gets you into the discussion of, do you find yellow flags? Do you find red flags? Right?
You invite them over. And you're
so,
interviewing them as much as they're interviewing you.
And oftentimes there's what we refer to as scope creep, right? You get a team in there and they're like, well, but this community is growing. There's 10,000 new housing permits. There's no houses yet, but we want to be the first one here. Or it's, well, but we need to have these 7 other service lines that you can't put in a small format facility. It doesn't economically or practically make sense. So you start to flesh out, what are they real? And I don't mean this disrespectfully to anybody, but what are they trying to accomplish? Are they really trying? They want a 100-bed hospital, but their CFO is saying you can only get something smaller, or are they really aligned around this is great care delivery and benefits our system?
Are you there for these conversations based on your experience?
It depends. Typically not the first go round. I mean, our operations team and development team and physician leadership team will be there, but I always have a dialogue directly with the CEO in every one of our cases. And I'm a huge believer in relationship capital and investing that time. There's no doubt we're going to have issues that come up in any one of our partnerships, right? But being open and transparent, being able to talk about it, we'll get to resolution more quickly. And so, you could pick any one of our partners. I mean, I talk to the CEOs quarterly, just understand strategically what he or she is thinking, what we're doing, how are our teams working together. And I'm a big believer in let's not let something fester. If you're hearing from your team that we're not doing something that you need, first line of defense is go to our CEO, go to our team, but don't ever hesitate to call me and say, hey, we have an issue.
And you have parameters on what upper lower thresholds are for timeline as well. Like you're going to be patient, empathetic. Hospitals have a lot of stuff going on, but you're not going to spend 15 years to find out whether.
No, I mean, look, and that's where I went back to the arrogant statement. We have a defined period of time. I won't say it, but it's it's within a short number of months. If a health system's not willing to commit to come spend time and see the facility, we'll oftentimes go pencils down and just say,
That's a good test.
Fully appreciate that you have a lot of other things going on. When when we're ready to do this together, let's go do it. But otherwise,
a commitment test.
Opportunity cost, and it sounds crummy, and I don't mean for it to sound crummy. It's just it's a discipline that we've tried to instill.
Your crummy spider senses are too finely tuned. I would down notch them one bit. Doesn't sound crummy at all. It sounds very reasonable. All right. In the minutes that we have left, private equity. You've had a partner all this time, one of the most well-respected brands in the space, Welsh Carson. Can't really do much better than Welsh. Other than singing their praises, what role have they really played over the years? What would this business be without Welsh?
Good question. They've been a great partner. They've been very patient. They have allowed us to really focus on what we believe matters. They challenge us often on. I was actually having this conversation earlier this morning with one of the Welsh guys. Is we've and I talked about it earlier, have been very focused on core competencies. We have 3 strategic priorities today, and they've been the same for 4 years. And so oftentimes at board meetings, particularly around budget and annual strategic planning, there's, well, what can we do over here, or what can we do over here? And they've allowed us to really, my comment to them has been, we've had a ton of success with our 3. We still think there's a ton of white space on the 3, the strategic priorities. If you want us to add a 4th, we work for you, I get it, to a degree, or work for the board, but you're gonna have to take something off our plate. And the answer typically has come back to keep doing what you're doing. Where I think they add a ton of value, and Welsh is not the only one that does this, but Welsh is heavily invested in a resource group where we have experts that we can lean on with managed care contracting, with business continuity and cybersecurity, with people experience in HR, where we can benchmark ourselves against the portfolio and others. On the business continuity and cybersecurity side, it's probably 3 or 4 years ago in one of our CEO forums, is we all said, look, we're spending a ton of time trying to get our arms around this, a ton of time and money. And so they brought in an enterprise solution where the entire healthcare portfolio went through the same process of assessing where do you sit on the continuum, how much are you spending relative to effectiveness. And so it gave you a comparative set on a common set of themes that really allowed us to accelerate our progress. But I would say, generally speaking, a lot more of what I would call kind of first tier private equity groups have invested in resource groups that can benefit their portfolio with expertise on procurement, managed care, IT, you name it, where you're not necessarily out on an island trying to solve every issue on your own. You get the benefit of the collective.
I think that's great insight, and I would imagine it's extremely valuable. Victor, I want to thank you for your time. I hope you had fun.
I did. It was good. All right. See you.
Take care, my friend.